Hello, my name's Steve Fordham. I'm a consultant in emergency medicine from the Royal Devon and Exeter Hospital.
And my name is Martin Dorr. I'm an emergency medicine trainee in the South West Peninsula Deanery.
This is a podcast exploring the NICE Clinical Guideline 160, Feverish Illness in Children, Assessment and Initial Management in Children Younger than 5 years. We aim to highlight the approach to the assessment and management of feverish illness in children in the emergency department. Children with fever account for as many as 20% of emergency department visits. Sepsis is a major cause of morbidity and mortality in children, and although mortality rates are lower in children than adults, they are estimated at about 10% in severe sepsis. It has been stated that for every extra hour a child remains in shock, their mortality rate doubles.
We all feel the challenge when picking up a child with fever. Prevalence of serious illness has been reported as low as 0.8% in primary care and 7.2% in secondary care. It is therefore far more likely that the child with fever has a viral illness that will resolve without consequence, but there is always a worry of missing the early meningococcal disease or the serious bacterial infection, SBI. Thanks to NICE, there is a framework which can help us differentiate the early septicemia from the simple viral illness, or the high risk from the low risk child with fever. This guideline was originally published in 2007 and was updated in May 2013.
When a child arrives in the emergency department with a history of fever, it goes without saying that we should measure and record temperature, heart rate, respiratory rate and capillary refill time as part of the routine assessment or triage. Since it's the fever that's worrying us, we need to measure this correctly. In infants under the age of 4 weeks, we should measure body temperature with an electronic thermometer in the axilla. In children aged 4 weeks to 5 years, we can use either an electronic thermometer in the axilla, a chemical dot thermometer in the axilla, or an infrared tympanic thermometer.
It is important to remember that forehead chemical thermometers are unreliable and should not be used by healthcare professionals, and that reported parental perception of fever is important and should be considered valid and taken seriously.
When interpreting observations, NICE recommends using the APLS criteria for a tachycardia. This would be a heart rate of over 160 in a less than 12-month-old, over 150 in a 12 to 24-month-old, or over 140 in a 2 to 5-year-old. We should be clinically aware that a sustained tachycardia is a concerning feature and puts a child in at least an intermediate risk group for serious illness.
NICE have produced a traffic light system which puts patients into green or low risk, amber or intermediate risk, and red or high risk groups, depending on presenting symptoms and examination findings. Although fever in the young infant is relatively uncommon, when it occurs there is a higher risk of SBI than in later life. It is therefore important to recognise that children less than 3 months with a fever greater than 38 degrees are already in the high risk group. These require senior paediatric review and full septic screen. This includes routine bloods, blood cultures, urine dip and culture, and likely chest x-ray and lumbar puncture.
The traffic light system has been broken down into the 5 groups of colour, activity, respiratory symptoms and signs, circulation and hydration, and other.
Symptoms or signs in the red or high risk group for serious illness include skin changes such as being pale, mottled or blue, or the presence of a non-blanching rash, altered level of consciousness including no response to social cues, or weak, high-pitched or continuous cry. Respiratory compromise with sustained tachypnea, especially respiratory rate greater than 60 breaths per minute, moderate or severe chest indrawing. Evidence of shock including reduced skin turgor or neurological signs such as bulging fontanelle, neck stiffness, focal seizures or status epilepticus.
Children presenting with fever and shock should be given an immediate intravenous fluid bolus of 20 ml per kilo and immediate parenteral antibiotics, especially if they are shocked, unrousable or showing signs of meningococcal disease. A third-generation cephalosporin is an appropriate initial choice, and for children younger than 3 months, an antibiotic active against listeria, for example ampicillin or amoxicillin, should also be given. Intravenous acyclovir should be considered if patients present with focal neurological signs, focal seizures, decreased level of consciousness, or other clinical symptoms and signs suggestive of herpes simplex encephalitis. The general management of children who present with fever and no apparent source and one or more of these red features involves a set of routine bloods, urine dipstick and urine culture. Lumbar puncture and chest x-ray should be considered in all of these patients according to the initial clinical assessment.
In children who aren't in the high-risk group, important intermediate risk features include decreased activity or abnormal response to social cues or stimulation, sustained tachypnea appropriate to age range or other clinical chest signs, those with signs of hypovolemia, including prolonged capillary refill time, dry mucous membranes or reduced urine output, or a fever duration of more than 5 days, rigors or a clinical suspicion of a musculoskeletal source of infection.
Children with a fever without an apparent source who have one or more of these amber features should always have a urine dipstick and culture collected. Routine blood tests, lumbar puncture in children less than a year, or a chest x-ray in a child with clinical respiratory signs should be performed unless deemed unnecessary by a paediatric specialist. For children with a fever of more than 5 days, it must be remembered that the differential diagnosis of Kawasaki's disease comes into play. The diagnostic criteria for this is at least 4 of the following: bilateral conjunctival injection, change in mucous membranes, change in the extremities, a polymorphous rash, and cervical lymphadenopathy.
The well-looking child with no amber or red features and normal physiological observations are considered low risk. A urine dipstick should be obtained in all feverish children, and a microscopy and culture should be performed in those under 3 years, as highlighted in the NICE Clinical Guideline 54, Urinary Tract Infections in Children.
When managing the fever, we should be using either paracetamol or ibuprofen, especially if children appear distressed. We should not be using antipyretic agents with the sole aim of reducing body temperature. We should not be giving both agents simultaneously and should consider alternating paracetamol and ibuprofen if the distress persists or recurs before the next dose is due. Tepid sponging is not recommended, and children with fever should not be underdressed or overwrapped. It's important to remember that a fever that subsides after antipyretics cannot be dismissed as viral in origin.
Children in the green group or in the amber group with an identifiable source of infection or whom are improving can be considered for discharge home with safety netting. It must be noted that when looking for a source of fever, mildly pink tympanic membranes or red throat do not constitute a focus. The safety net should include the following: providing the parent or carer with verbal and written information on warning symptoms and how further healthcare can be accessed, arranging further follow-up as required at a specified time and place, and liaising with healthcare professionals, including out-of-hours providers, to ensure direct access for the child if further assessment is required.
Written advice sheets should include information on fever management, oral hydration, clinical signs and symptoms to look out for, and what to do in the event of deterioration. In summary, childhood serious bacterial infection can be difficult to diagnose in early stages, and if not treated promptly can have tragic outcomes.
Every child with fever should be triaged promptly with full set of observations, including a temperature.
Use a traffic light system to risk stratify the febrile child.
Red patients are high risk and should trigger prompt investigation, paediatric specialist review, and consideration for early antibiotics and fluid therapy.
Amber patients should be closely monitored and immediate treatment tailored to the suspected source of the fever.
Green patients can be managed conservatively with consideration for discharge with appropriate safety netting.
All patients should receive antipyretic therapy, regular observations, and urine dipstick testing.
You've been listening to Martin Dorr and Steve Fordham at the Royal Devon and Exeter Hospital. You can follow us on Twitter at EMExeter. Thanks for listening.